Hello.
All right. Good morning, all, and good afternoon. I'm very excited to be part of this conference on clinical research and clinical trial summit. Hope you can hear me now.
Yes, we can hear you.
All right. Yeah, I am Sadiq Muazu Maifata. This moment I will be presenting on the role of the biomarkers as stated, and that is phospholipase A2 receptors and thrombospondin type 1 domain containing 7A in diagnosis, monitoring, and prognostication of primary membranous glomerulonephritis under the following headline. Membranous glomerulonephritis is a form of glomerular disease characterized by deposition of immune complex within the subepithelial aspect of glomerular membrane and formation of perpendicular projections between the podocyte cytoplasm and glomerular basement membrane. It is one of the most common causes of chronic kidney disease that is highly linked to frequent dialysis and also progression to end-stage renal disease. So membranous glomerulonephritis is of two types. The most commonest, which is the primary membranous glomerulonephritis, otherwise known as the idiopathic, which is seen in about 75 to 80% of cases. And the other one, which is secondary to other diseases, such as the lupus nephritis, diabetes nephropathy, hepatitis B and C, sarcoidosis, among others. So nephrotic syndrome is the commonest presentation of membranous glomerulonephritis, which is account for up to 20% of Hispanic and African American. In children, although nephrotic syndrome is common, but as part of presentation of membranous glomerulonephritis, it is seen in about 1.5 to 9% of cases, while in adults it's seen in 25 to 35% of cases. So the incidence of membranous glomerulonephritis peaks in the 4th and 5th decades of life, with more men affected than women. That is mostly men to women ratio of 2 or 3 to 1. The exact cause of membranous glomerulonephritis remains unclear, and the disease cause varies significantly. Although biopsy is the mainstay or the confirmatory test for membranous glomerulonephritis, the clinical outcome is often variable and often unpredictable. Sometimes patients with secondary membranous glomerulonephritis may present with the features of membranous glomerulonephritis for months or years before the appearance or before the manifestation of the underlying cause. So in this case, the patient might have undergone a lot of series of biopsy to make the diagnosis, and also may have been exposed to toxic chemotherapeutic drugs, which is very cost, and most patients, especially in developing countries, may not afford most of this treatment. So for this, sometimes also biopsy may be delayed in certain conditions associated with coagulopathy, or maybe patient that is on anticoagulant may have delayed biopsy. In this case, this may lead to what? Delayed in the diagnosis of membranous glomerulonephritis. So for this, the discovery of a biomarker known as phospholipase A2 receptor, which is the main biomarker for the primary membranous glomerulonephritis, and thrombospondin 1 domain containing 7A, which complements the activities of phospholipase A2 receptor, is usually seen in patients that are phospholipase A2 receptor negative variants. So this changes the dimension of diagnosis and monitoring of membranous glomerulonephritis. After that, there are several studies that were conducted and suggested that phospholipase A2 receptor could be used as a prognostic biomarker for primary membranous glomerulonephritis and thus used in monitoring primary membranous glomerulonephritis patients. So despite all the progress made on the serum phospholipase A2 receptor and thrombospondin 1 domain containing 7A as a diagnostic and prognostic biomarkers for primary membranous glomerulonephritis, studies on the urine phospholipase A2 receptors and thrombospondin 1 domain containing 7A are lacking. So this study contribute to highlighting the role of serum and urine biomarkers, phospholipase A2 receptors and thrombospondin 1 domain containing 7A in early diagnosis, treatment decision, monitoring, and prognostication of primary membranous glomerulonephritis patients. So we gotten a full clinical workup and clinical correlation to classify the biopsy as either primary or secondary membranous glomerulonephritis. Then for other patients presenting with clinical manifestation, such as hepatitis B, lupus nephritis, and secondary causes, we use the clinical parameters or clinical diagnosis to make the diagnosis, to rule out the primary causes. So in this case, what we did is we make use of a primary membranous glomerulonephritis as a diagnosis of exclusion. We excluded secondary causes for us to arrive at the primary membranous glomerulonephritis. Although in some centers, they make use of electron microscope, which is far more effective than this. So in Malaysia, some of the patients had this especially the earlier patients, the later patients, those in close to around 2019, had the electron microscopy for the diagnosis, but there are very few. That's why we couldn't include that as part of our main criteria. So after obtaining ethical approval from National Medical Research Register, we have access to the Renal Biopsy Registry, where we obtain a renal biopsy record from January 2012 to October 2019. Among the record, we included the demography, the clinical pathology, laboratory, and treatment. So we were able to get 125 patients. So after the exclusion and other things, and also the issue of consent, we are able to seek consent from 69 patients, among with including 45 primary and 24 secondary patients, the secondary membranous glomerulonephritis patients. We also included 24 apparently healthy subjects. We invited the patient and collected their serum and urine for the serum and ELISA test to check for the presence of the two biomarkers, PLA2R and THD7A. So this is the reference parameters we use for both the laboratory biomarkers and the biomarkers. So the statistical analysis, we make use of SPSS version 25. Normally distributed continuous variable were expressed as mean standard deviation, while those that are not normally distributed, we make use of median interquartile. So we also use of the multiple regression analysis to determine the factors associated with membranous glomerulonephritis, which we use receiver operating characteristic curve to validate our result. Also, we make use of less than 0.05 at the statistical level of significance. So this is the table at the time of biopsy. So most of the patients, that's for both primary and secondary, are within the age 30 to 40. That's a very young age. Also, the the male to female ratio for primary and secondary have more male in the case of primary membranous glomerulonephritis compared to female, while in the case of secondary membranous glomerulonephritis, we have more female than male. This is linked to the high prevalence. This is, hello? This is linked to high prevalence of lupus nephritis in Malaysia, which account for the high prevalence of secondary membranous glomerulonephritis, and it mostly affected female. Also, if you look at our table, the nephrotic range proteinuria is very common in primary membranous glomerulonephritis. About 80.8% presented with nephrotic syndrome, while in the case of secondary, we have 59.1. Also, in the other table, we can see that serum creatinine is very high in primary membranous glomerulonephritis, about 87.2%, and 63.6% in the case of secondary membranous glomerulonephritis. So this is the correlation table to determine the relationship between the biomarkers and this is the table at the end of the follow-up. So at the end of the follow-up, we calculated the estimated glomerular filtration rate and urinary protein creatinine index. So we realized that about 29.8% of those with primary membranous glomerulonephritis are at high risk, while 31.8% of secondary membranous glomerulonephritis are at high risk. So in the case of urinary protein creatinine index, 57.4% are yet to achieve remission. That's for 57.4% of primary membranous glomerulonephritis are yet to achieve remission, while in the case of secondary, 77.3% are yet to achieve remission. So in the case of after the test of biomarkers using the ELISA method, we were able to get 13 to be positive for FLA-A2R, that is using the ELISA test for primary membranous glomerulonephritis, and 1 is positive for the secondary membranous glomerulonephritis. Although phospholipase A2 receptor is associated with primary membranous glomerulonephritis, but obtaining 1 patient from the secondary to be positive is not surprising, because the patient, after checking, we realized that the patient has a hepatitis B, which was linked to a phospholipase A2 receptor. So hepatitis B also is linked to phospholipase A2 receptor. That's why we have the positive patient. Then the value for serum and urine are all the same. In the case of serum thrombospondin 1 domain containing 7A, 4 patients from primary membranous glomerulonephritis are positive, which are not positive in the case of phospholipase A2 receptors. There are those that are negative for phospholipase A2 receptors, but positive for THSD7A. And also 2 of them from the secondary membranous glomerulonephritis are positive, 1 of which is linked to the malignancy, and malignancy is associated with the positivity of THSD7A in certain issues. Then if you look at the serum THD7A for both primary and secondary membranous glomerulonephritis, both the results shows negative. This shows that we cannot assess the biomarker THSD7A in the urine. Then the correlation table to find the relationship between the biomarkers and also among the laboratory parameters. In this case, we make use of these laboratory parameters because they are the established parameters used in monitoring patients with chronic kidney disease. They used to assess the response to treatment and also the likelihood of progression to end-stage renal disease. So if there is a relationship between these biomarkers and these laboratory parameters, it shows that we can also use the biomarkers to monitor the disease condition. The first is we make use of the serum. We find a relation between serum and urine phospholipase A2 receptors, which the relationship is very significant, 0.9. And also the serum, the relationship between serum and laboratory parameters. We have the serum phospholipase A2 receptors have a very good relationship with urine protein creatinine index. Then in the case of urine phospholipase A2 receptors, it has a poor relationship with albumin, with urea, and also a fair relationship with urine protein creatinine index. Then we also find a relationship between serum and urine THSD7A. We realize that there is no relationship. Also, when we try to compare it with other laboratory parameters, we couldn't find any relationship with any of these laboratory parameters. Then the next table is on the regression table. Make use of the regression table to find the association between the primary membranous glomerulonephritis and estimated glomerular filtration rate less than 60, which is equivalent to a chronic kidney disease greater than or equal to 3. So in this case, we found out that we first performed our simple linear regression, and we realized that age, serum phospholipase A2 receptors, and urea have an association with primary membranous glomerulonephritis. Before then, we performed our multiple linear regression, and we found out that the urea increases the risk of primary outcome, that is the chronic kidney disease greater than or equal to 3 by the odds of 69.1% for any unit increase in urea at 95% confidence interval, while high serum phospholipase A2 receptor titer increases the risk of the developing, that is progressing to chronic kidney disease greater than or equal to level 3 by 4.8 odds, compared with those subjects with normal serum phospholipase A2 receptor titer. Then the next table is we try to find the relationship with between primary membranous glomerulonephritis and urine protein creatinine index, which is also very important in monitoring the prognostication of disease. This shows whether the patient achieved remission or not. In this case, after performing our simple linear regression, only creatinine, estimated glomerular filtration rate, and urine phospholipase A2 receptors are significant. So the table, which is for the multiple linear regression, shows that for any rise in unit of urine phospholipase A2 receptor titer, there will be increase the risk of not achieving remission by 18.4 or 0.5% at 95% confidence interval. So in conclusion, serum phospholipase A2 receptors and thrombospondin 1 domain containing 7A and phospholipase A2, urine phospholipase A2 receptor are essential biomarkers for diagnosis, treatment, and decision prognosis of patients with primary membranous glomerulonephritis. In addition, biomarkers should be clinically recommended to make a diagnosis of primary membranous glomerulonephritis in patients who were unable to undergo early renal biopsy, and also to monitor the response to treatment. So some of our limitations and recommendation. A prospective study design will be preferred with more patients to assess the serum and urine phospholipase A2 receptors and thrombospondin 1 domain containing 7A at interval. Then also, this will effectively monitor the disease condition and determine the prognosis of patients with primary membranous glomerulonephritis. Thank you for listening.